Yeah, I came up with the mnemonic for the P's because, we do a lot of teaching as rheumatologists, whether that's a medical student, a resident, a fellow. But also remember now we have a whole group of other clinicians called the APCs, Advanced Practice Clinicians or Advanced Practice Practitioners. And over the years, I've had several. I have 5 that work with my practice right now. And so I wanted to come up with a way to say, hey, if I'm seeing a new patient for rheumatoid arthritis, a new patient for psoriatic arthritis, that everybody's going to be getting the same type of workup. I don't want somebody, I forgot to do this, I forgot to do that. So I said, hey, let's come up with a catchy way of teaching that. And so we did that and developed this whole P's concept, and that's what we did. So not only to treat the residents and fellows that we work with, but for students and APCs, and it's actually that kind of stuck in that regard. Remember that many of our diseases that we can see, not only they have joint and skin involvement, but they can have pulmonary involvement as well. I go back to when I was doing my fellowship at Duke, we do saw a significant amount of people with rheumatoid lung disease. Now, how do we pick it up? You do a chest x-ray, and you see these nodules. So not only looking for inflammatory change, but you're looking to see whether that patient has been exposed. So I practice in a suburb of Milwaukee, and we have farmers in this area who've been exposed to things like blastomycosis. So you might have a rheumatologist who practices in Arizona where they have coccidiomycosis, or where I grew up in South Carolina where you have tuberculosis. And all of those, you have these nodules. The body's immune system kind of protects those things, kind of wall them off, and it's kind of like an eggshell inside of the lungs. So I want to see where that patient starts at a baseline as to when we do the chest x-ray. The other good news is if a patient is on a biologic drug, that patient gets sick, and a good example is COVID, right? I can take a chest x-ray today and go back and say, hey, wait, that chest x-ray was clear last year. Now you really do have something that's going on. So I do that at baseline, and any time where I need to look at something, whether that's for an acute infection or was a change in the disease activity. One of the P's is a panel for the lipids, because it turns out when the body's immune system is to make things like it's going to give fuel the body's energy. For example, cholesterol was a fat that we use, and that fat is then converted down the road into glucose. But remember also, in response to inflammation, the liver, which is one of the big organs that makes acute inflammatory proteins like C-reactive protein or interleukin-6, all those different things are generated by the liver. So when the liver gets tickled from inflammation, or where it gets tickled from inhibiting a cytokine like interleukin-6, or inhibiting a pathway like a JAK-STAT pathway, then the liver will begin to make other things as normal makes. And one of those things are going to be the cholesterol. When we think about putting people on these molecules, whether it's an IL-6 blocker or a JAK antagonist, we know that, hey, that the liver will make things it normally does. But guess the good news, it doesn't change the ratio. So many people know about the bad cholesterol, that's the LDL. Your body doesn't make more LDL compared to everything. Everything goes up, respectively, and therefore the ratio doesn't change. Here's the good news. Once that patient has had that initial kind of response to whatever medication or inflammation, then the body's liver will kind of adjust and kind of go down. And that's why you look in the package insert, the FDA made many of the companies say, hey, you don't need to do a lipid panel today, but you want to do it at 12 weeks once they've been on the new therapy, and then maybe repeat it in another 12 weeks to see if that number has kind of gone up and down. So the lipids play an important role in not only homeostasis for our body, but it also can be a good indicator of how your body is responding to inflammation and a good indication of how your body is responding to metabolizing many different drugs. When you have patients who are our younger patients, we have patients who present with us at 67, 80 years old, but I have a significant number of patients who develop to the 20, 30, 40 years old, right in the middle of their childbearing years. So that's why one of the P's is get a pregnancy test just to make sure that I'm going to monitor that patient effectively. I know there are guidelines out there. The guidelines say that, yes, when I look at a whole population, some of these drugs are relatively safe. But I tell people, as a parent, my wife and I had a miscarriage at 12 weeks, and we're both healthy on no drug. I said, it's a challenge not only for a normal couple to have a normal baby. The baby comes out, I want all 10 fingers, I want all 10 toes to be there. And when we start playing around with these drugs, it's a different animal. So I want to make sure that that patient is as healthy as possible. So the guidelines may say that some of these drugs are safe, but if my young daughter is about to have a family for the first kid, I want to make sure all the fingernails are there. I want to make sure everything is going to be like it should. So I really think the pregnancy is a portion of that. And then have to make a second. Second will be infection, right? We want to make sure they're not going to get a fungal infection. make sure they're not going to have pneumonia, all those different things. And that's what this kind of comes in. But I think sometimes we become callous in treating these patients with all our different drugs. And therefore, oh, yes, it's no big deal. If they get pregnant, we can deal with it. It is a big deal for a number of different families. And I think this is something as a rheumatologist, which should be top of mind. Yeah, one of the piece that the people always forget is, so, hey, let's talk about the pneumococcal vaccine. Oh, yeah, I don't know if they really need it. Well, is it a new pneumococcal vaccine and which one's out there? I haven't heard the TV commercials. So all those different things. So we actually order these. We have 3 vaccines that we give out in our clinic routinely. The pneumococcal vaccine, we give the flu shot, and we give the shingles vaccine. And that's before we start any kind of medication. Many doctors, as no, we're going to let the primary care doctor take care of that. And then primary care doctor, they treat populations where we treat individual patients where we actually, quote unquote, somehow immunocompromise them by blocking certain cytokines, by blocking certain targets like that JAK-STAT pathway. So as an immunologist, I want to do everything I can to boost that patient's immune system. So when they walk out the door of one of my drugs, their body is able to fight off any offending infection, whether it's viral, bacterial, that is possible. And that's what I think some of my colleagues overlook sometimes.